Thanks for having me again. So I know a decent number of you on the call, but for those of you who don't know me, I'm Dave. I'm one of the pediatric intensivists at Nemours. Um, so my clinical time is in the ICU, but I spend a good chunk of my time in the lab working on a variety of projects, all of them somehow related to extracorporeal life support or ECMO, ECLS, all sort of the same thing. But I'm going to talk about one of the projects that was funded by the INBRE for the last year. It was funded by the pilot program. And it's a project where we were looking at how to best rest and recover the lungs for patients, or in our study case, pigs, who were placed on extracorporeal life support after acute lung injury. The only disclosure is that I received complementary PFOB, which is the chemical we use from Floramed. The disease entity that we're studying is pediatric ARDS, which is pretty common. We see it a lot in the ICU. In the most severe cases, it's actually a really high mortality disease with mortality rates approaching 50%. And certainly that applies to patients who are so severe that they need to be placed on ECMO. Typically, the pathogenesis starts with an injury to the lungs, whether it's a direct injury like pneumonia or trauma or aspiration, or an indirect injury like sepsis or blood transfusion. Ultimately, ARDS progresses to inadequate gas exchange, hypoxemia, meaning low oxygen levels in the blood, high CO2 levels, which leads to acidosis, and then all that together creates a milieu that is not good for the organs, and so ultimately leads to multi-organ failure and death. So extracorporeal life support, or ECLS, also known as extracorporeal membrane oxygenation, or ECMO, is a life-saving therapy for severe pediatric ARDS. And essentially what it is it's a external oxygenating device, sort of like an artificial lung in some ways. What you do is you place large cannulas in the neck, typically, sometimes in the groin, sometimes directly in the heart, but regardless, large cannulas that are able to pump large volumes of blood outside of the body through an external oxygenator. The oxygenator then leads to gas exchange across the semi-permeable membrane, so oxygen goes into the blood, carbon dioxide comes out of the blood. And this allows, the patient to normalize their oxygen and CO2 levels if their lungs can't do it. But another big benefit is that it can allow the lungs to potentially rest and recover while the external device does all the work. And why is lung rest so important? Well, it's because the ventilator itself, which is necessary for survival in patients with injured lungs, can actually do more damage, or do a lot of damage to the lungs. And this has been described for decades, a concept of ventilator-induced lung injury, that the pressures from the ventilator can actually further damage the small and fragile alveoli, especially when the alveoli are injured, such as in ARDS. And although it's, as I said, the mechanical ventilator is sometimes necessary to keep the patient alive, it really can lead to a spiral, the lung injury spiraling out of control. And so, there's a variety of mechanisms by which the ventilator can injure the lungs that are listed on the right. But ultimately, what ECLS allows us to do is because oxygenation happens outside of the body with a device, it allows us to turn the ventilator down to what are supposedly rest settings or gentle pressure settings. The problem is that nobody actually knows what to do and how to actually ventilate the lungs for patients on ECMO. It's essentially made up. We kind of just pick pressures that seem reasonable and are lower than typical pressures. This is a study that I did when I was a fellow, and part of it was just looking at what do people do for patients who are on ECMO. And you can see that there are some commonalities, that people oftentimes use a expiratory pressure of around 10, but there's a big variety. Some use as high as 20 and some use as low as 0. And same thing with delta pressure, respiratory rate, and fraction of inspired oxygen. It's sort of all over the place in terms of what people actually do. And there's no real standard and certainly no evidence-based standard for how to do it. Now, on the other hand, so an interesting idea that I think has evolved between myself and Dr. Schaefer here at Nemours is this idea that maybe gas is not even, maybe we should think outside the box and move away from gas ventilation entirely, and think about using liquid to help rest the lungs. It's a concept that I've termed liquid lung rest, or LLR. And there's some physiologic reasons why LLR may actually be better than gas ventilation. This idea originally came up when I was thinking that, well, when you're on ECMO, you don't actually need the lungs. You couldn't use whatever liquid you want. You can put whatever you want into the lungs, and because it doesn't really matter, as long as it helps heal the lungs, because you're not using the lungs and the oxygenator is doing it. Even if you put things that impair gas exchange, that's not a problem. Now, of course, there are chemicals that don't impair gas exchange, and I'll go into that for a little bit. But getting into the physiology of why liquid lung rest might be better is this was actually demonstrated. This graph in particular was published in 1971, but actually the data for this graph, I think, was gathered in the 1930s. It's a really old study where they took a cat lung and filled it either with saline or with air, and it looked at how much pressure it took to get a certain volume. And as you can see, it takes much less pressure to get a larger volume with liquid. So meaning that you don't need the higher pressures to open up the lungs if you lose liquid. Whereas with gas, especially injured lungs, it could take a lot of pressure in order to get a very small amount of volume. The other thing that so one benefit is this increased pulmonary compliance, which means less pressure for more volume. The other piece that's important is that liquid can actually recruit the alveoli in a more homogeneous manner. So gas, because of, especially in injured lungs, because of the loss of surfactant function, gas will preferentially go to certain alveoli and will overdistend some and actually not inflate any others at all. Whereas liquid will not have that preferential sort of movement and will more homogeneously open up all the alveoli. The other possibilities are thinking about more effectively delivering therapeutics like antibiotics, immunomodulators, which are obviously much easier to deliver in a bulk liquid flow as opposed to having to nebulize it, which can lead to delivery problems. And then finally, thinking about pulmonary clearance, like using liquid. We use saline to kind of get the mucus and bacteria and dead cells out. If you just had liquid in the lungs, it would be much easier to clear out all the basically necrotic dead stuff in the lungs, which allows better healing. So with that, we actually used a molecule called PFOB, which although it's not necessary to do gas exchange, PFOB, we chose that for a variety of reasons, in part because it has been used in the past for liquid ventilation. So PFOB actually does carry gas and CO2 and can be used for gas exchange. And so we don't necessarily lose that property by going to liquid. And we chose PFOB, one, because we knew it's safe in humans, and two, because after the lungs heal, there's a potential for easy transition off of ECMO back to normal breathing, because PFOB will just sort of evaporate slowly over time. And because it can be used for ventilation, you can actually create a nice transition period between full ECMO support and not. So our hypothesis was that if we infuse PFOB, it will better recruit the alveoli, and this will translate into better compliance and reduce inflammation. So we did this study in pigs. And so the idea is we injure the lungs of a pig with oleic acid, which is an IV infusion that causes severe alveolar and capillary damage in the lungs. As soon as a sufficient injury is obtained, we then cannulate the pigs to ECMO, which we do here in our pig lab. And then we randomize them either to gas ventilation with sort of our standard Nemours rest settings, which is an end expiratory pressure of 10, and then inspiratory pressure of 20, and a respiratory rate of 10. And we either do that or we randomize them to liquid lung rest, which actually uses the same ventilation settings, but then we add an additional 5 mLs per kilo of PFOB. And then our outcomes are looking, our primary outcome was looking at pulmonary compliance. So meaning how much volume you get for a given pressure. And then we looked at cytokine levels, both in the blood and the tissue. And then we also looked at histology and looked at how open the alveoli were at the end of the study. So we did this for 4 hours. So it was a short sort of pilot study to look at short-term effects. So thus far, we've done 18 pigs, 9 per group. And this is the this is an image of our setup here. So this is the pig, obviously. This is the ECMO cannulation. So you can see these large cannulas in the neck. That the blood is, it's a little hard to tell in the picture, but this is the venous blood that's coming out, going through our pump, coming out to the oxygenator, which is this little small blue thing down here, and then going back to the pig. And so all of this is allowing for full extracorporeal gas exchange. This is the compliance over time. So you can see in the gas ventilation in both groups, actually, you start with a relatively normal compliance between 1 and 1.5 approximately of static compliance. After the injury, you get a dramatic reduction in compliance, which is consistent with a severe injury. And then in the gas group, you really see no real improvement over time in compliance, and it sort of stays the same or maybe even drops a little bit. Whereas in the liquid lung rest group, you get a little bit of a bump, not all the way back to baseline, which is sort of a statement to how severe the injury is, but you do get a little bit of improvement, and it was statistically significant. So we did see improvement in compliance, which was our primary outcome. Looking at histology, this supported what we were seeing on the ventilator in terms of compliance. So I have these a little bit backwards, but start over here on the right, looking at the lung section. So this is actually taken from the most dependent, so the most collapsed area of the lung in both cases. So this is the bottom of the lung. You can see in gas ventilation, you see almost complete alveolar collapse. There's a few open alveoli here and there, but for the most part, this is all collapsed lung. Whereas if you look at the liquid lung rest group, we see it's definitely not normal, but it's a lot more open. You can see a lot more airspace here. And if you quantify this by the density, so if you just take all of this area and you see how much of it is air and how much of it is not air, higher meaning more, or higher airspace density meaning more open. So what we saw was actually a non-statistically significant difference between gas and liquid lung rest. But I thought what was really interesting, this is a violin plot showing the distribution. And I thought what was really interesting is that although the median was not statistically significantly different, there was a little bit of a trend increase, but more importantly, you really didn't see a lot of this complete collapse in the liquid lung rest group. The distribution was much tighter, which sort of visually suggested that there was more homogeneity in terms of how the alveoli were open. And whereas in this group, there was a lot that was completely collapsed, and there was even some that may have been perhaps over distended, which goes along with this idea that which we talked about earlier, where gas ventilation can cause some overdistension and complete collapse at the same time, which then can result in a median that is around the same, but still not normal. So with that, then I looked a little further at regional heterogeneity. So if this is the lung, we divided it into 6 groups, 6 zones rather. So one is the least dependent, meaning so dependent means like at the bottom, like where gravity kind of has the most effect. So this is the top of the lung where gravity has the least effect, the top and front. This is the back and bottom, lower lobe, where gravity has the most effect. And so this generally is the most collapsed area. Number 6 is the most collapsed area in ARDS or lung injury. And so if you look at the airspace density by zone, we don't see much statistically significant differences until you get to zone 6. And then you see a dramatic difference in terms of airspace density. And that I think goes along with, suggests 2 things. One is that the 5 mLs per kilo may be on the low end of the dosing, which was intentional. We did start at a pretty low dose. Expected dose, the whole lung, to fill the whole lung would be closer to 20 to 30 mLs per kilo. And so, we're probably only filling maybe the bottom parts of the lungs. But even more importantly, this is the area that is most affected, as you can see, by gas ventilation, is the most collapsed, and that's where we get the most recovery with liquid lung rest. If we then quantify the overall heterogeneity, so what this is, a heterogeneity index is just the standard deviation of the airspace density over all the regions. So more variability means a higher standard deviation and therefore a higher heterogeneity index. So in this case, you look at the gas, there's a statistically significant higher heterogeneity index in the gas group versus the liquid lung rest. And this sort of all goes together, suggesting that liquid lung rest more homogeneously opens the lungs. Looking then at inflammation, this is the plasma cytokines. We looked at 6 different cytokines that are commonly affected in lung injury, and in all of them there was a trend towards increased inflammation in the gas group, which suggested more inflammation. Somewhat surprisingly, the only one that was statistically significant was TNF alpha, and I think part of this was because this actually only represents 6 of the pigs, or sorry, 12 pigs total, 6 per group. I haven't analyzed the last few, and so I think, and a lot of this is driven by 1 or 2 pigs, and so we'll have to see if this bears out over the final half of the analysis. In the last few minutes, just a couple of follow-up studies. So we did do a dosing. I did mention that 5 mLs per kilo was on the low end of the dosing. So I did a follow-up study looking at what is the optimal dose for PFOB. And so what I did was we did a lung injury, and then we either set the PEEP, which is the end expiratory pressure, at 0, 5, or 10, and then we serially added 5 mLs per kilo increments all the way up to 30. And so you can see that actually some expiratory pressure is really necessary. And I think this suggests that without expiratory pressure, the liquid is just flowing to the large airways and sort of occluding large airways and is not getting to the alveoli. And so this, I think, very clearly told us that you need some degree of expiratory pressure. And honestly, it seems like you might even need as high as 10, which is a moderate amount of expiratory pressure, although that is what we use. And so it seemed like the sweet spot was somewhere around 15 mLs per kilo, but anywhere between 10 and 20 would seem to be acceptable in terms of the optimal dosing with 10 centimeters of water for PEEP. And then finally, one of the studies that is now ongoing is trying to compare 2 different sort of advanced strategies. So, with liquid, I mentioned when you're on ECMO, you don't even necessarily need the lungs to do any work at all. So in theory, you could just sort of open the lungs and kind of leave them and not sort of cyclically inflate and deflate and inflate and deflate. And that would be fine as long as your ECMO circuit is working okay. And so that's what I call complete lung rest. So meaning no tidal ventilation at all. You just set an end expiratory pressure and you don't move the lungs from there at all. On the other hand, it is also possible that the lungs, and there's some evidence that the lungs need some degree of stretch in order to recover. That's really important for fetal development of the lungs, is this sort of practice breathing where you get some phasic tidal ventilation. So this question is in an injured lung, is it better to not move the lungs at all and just kind of keep them open? Or is it better to have some degree of stretch, intermittent cyclic stretch, but not obviously what we know is harmful is overstretching. And so using kind of a lung protective tidal ventilation and doing small stretches, is that better than no stretch at all? So that study is ongoing. So in summary, it looks like, based on our pilot study, liquid lung rest improves pulmonary compliance. It results in more homogeneous alveolar opening and probably reduces inflammation, although that piece of it is yet to be seen for sure. In the future, I'm looking at using potentially other liquids that are non-perfluorocarbon based, because as I mentioned earlier, we don't necessarily need the gas exchange properties of the perfluorocarbon. And so thinking about things that are more biologically active, either immunomodulators or antibiotics or things of that sort, might be interesting to look at. And then ultimately, this was a short study, it was 4 hours. That's really not enough time to see kind of long-term benefit of whether or not, ultimately we want to see whether liquid lung rest can get patients off of ECMO faster and recovered faster so that we can avoid some of the complications associated with ECMO. And that kind of work will require a multi-day study to look at do these benefits hold out over several days. And so that's study is just kind of in the concept preparation phase. And that is pretty much it. Some acknowledgements of funding, as well as the people in my lab and other people that have helped. This is my lab website in case you guys are interested. This is just one of the projects that's ongoing, and we have a lot of other interesting work involving medical devices and oxygenator devices that are also actively happening. So that, take questions.